Hello, my name is Bia Carlini, and I'm hosting the webinar today. I wear a couple of hats here at Northwest ATTC. We are giving one more minute to get it started, and I'll be with you shortly.
Yes.
Hello, everybody. So we are starting our fourth webinar today. It's my pleasure again. My name is Bia Carlini, and I work at Northwest ATTC. Among many other hats, I am the webinar series coordinator. We'll take questions at the end. We are starting now, and it's my pleasure to introduce our speaker today, Dr. Joe Merrill, who will share his expertise about the management of opioid use disorder in primary care. A little bit about Dr. Merrill. He is a UW Associate Professor of Medicine and is also a certified expert in addiction medicine. He has clinical and research expertise in primary care, addiction medicine, pain medicine, and HIV medicine. He is a member of UW School of Medicine College's faculty. He is active on educating students, both residents and practicing physicians. Dr. Merrill attended medical school at Yale University, and his clinical interests include complex primary care, addiction medicine, pain medicine, and HIV medicine. It's a great pleasure to host you today, Dr. Merrill. We are now transitioning the screen to Dr. Merrill so he can start his presentation.
Can you hear me okay?
We can hear you.
Great. Well, thank you so much for the invitation to present today. I'm going to be talking to you today about the management of opioid use disorder in primary care. And let's see, got to get the next slide to go. Okay, so we're going to start off with a case. This is a 35-year-old man with HIV and hepatitis C who was admitted to Harborview after an opioid overdose. So he had a complicated course. He had respiratory failure, and he had a deltoid abscess, a big abscess on his arm. And he needed operative debridement. He had a history of heroin use multiple times a day, as well as methamphetamine use, which has really been daily over the last 10 years. He's been disengaged from medical care. He does have a high HIV RNA and a CD4 count that's on the low side. He hasn't had any HIV complications, but really not engaged in care. And while he was in the hospital and in the ICU, he required high doses of opioids for pain control. So today I'm going to talk about the management of opioid use disorder in primary care. We're starting in the hospital, but this is mostly about primary care and connecting patients to care. We're going to talk a little bit about the opioid epidemic and then a little bit on pharmacotherapy for opioid use disorder. I do want to spend the bulk of the time on models of primary care of opioid use disorder treatment, specifically a program that we have at Harborview and a little bit spread around as well, called the Massachusetts Nurse Care Manager Model, and its implementation at Harborview. And then some program policy evolution, kind of how our program has changed over time in terms of our clinical practice. So the opioid epidemic, we've seen all this in the newspaper. About 2 million adults have prescription opioid use disorder. About 500,000 have heroin-involved opioid use disorder. 33,000 people died of an opioid-related overdose in 2015. Those numbers have only gone up since then. And we have noted increases both in HIV and hepatitis C cases, and in areas which were not so affected by this in the past, in rural areas, also among young adults. And this is all traced to injection use of opioids. So in terms of the origins of the opioid epidemic, if you haven't read Dreamland, which is noted at the bottom of the slide, it's a really good review. Not so much about treatment of opioid addiction, but really the origins of the opioid epidemic, going back into the 90s, where pain was really focused as a fifth vital sign, and there was a lot of push to do better pain control. This was associated with pharmaceutical company promotion of especially new long-acting oxycodone and morphine, and led to opioid overprescribing. The resulting diversion, widespread non-medical use of opioids became very common, especially among youth, and then kind of separate from this pharmaceutical opioid issue, heroin became much more widely available and less costly. So heroin, not just in rural areas, but in smaller towns, and Dreamland really goes into the origins of that aspect of the epidemic. Along with both of these, really little concern initially about opioid use disorder, and very limited access to medication treatment for opioid use disorder. Really a mismatch in that the areas affected by the opioid epidemic were areas that did not have methadone treatment and very little buprenorphine prescribing going on. So this is actually pretty old data, but documenting kind of the correlation of prescribed opioids. That's the green line on the top, kilograms of opioids sold, and then the bottom line, admissions for opioid use treatment, going up pretty much in parallel, along with deaths due to opioid overdose. This is old data, and newer data takes this a little bit more to the present. This is from the CDC. And you can see, so the first part of the slide before really ended where in the early 2010s, and you can see that since then, really, opioid overdose deaths have gone way up, especially even in the last year or two. You can see the changes. There was prescription opioids going up with deaths, and then more recently heroin, starting in around 2012, and this does correlate with the changes in the heroin market. And then you could also see the orange line, other synthetic opioids, that's fentanyl, and fentanyl is much more available in the East Coast than it is in the West Coast. We really haven't seen that much of it in Seattle, except in some tablets of oxycodone that are counterfeit. But we expect fentanyl to arrive at some point, and you can see this astronomical increase in fentanyl overdose deaths, mostly in the East Coast. And so we really haven't seen the top of this. You can see when it looks at natural and semi-synthetic opioids, that's like your average oxycodone, morphine, hydrocodone. You can see that deaths related to this have flattened out, and actually prescribing has gone down, but that has not affected overdose deaths in this country. So there's different aspects of this epidemic, the prescribing and the heroin and the fentanyl, and they're not all connected. So going back to our case, the acute pain service at Harborview was consulted early because of the need for high doses of opioids, and they used their multimodal therapy, including opioids. The patient, after he got out of the ICU, was initially pretty resistant to addiction treatment, but really as discharge approached, the pain medicine started to get tapered, he decided he wanted to get treatment for his opioid use disorder. He had been in treatment long ago with methadone, but he had been discharged due to ongoing methamphetamine use, which he wasn't really in his degree of desire to change, his methamphetamine use was much less than his opioid use. He'd never been treated with buprenorphine. And just to note, methadone maintenance programs nowadays don't necessarily discharge patients for methamphetamine use, but they did back then when he did it. And that was one of the reasons he was reluctant to seek treatment, because he thought he might not succeed. So this is the simple version of opioid addiction. You can see in acute use on the left side that people, when they use opioids, get euphoric. And you can see that over time that euphoria wanes somewhat. And then at some point people's euphoria, they get tolerant to the euphoric effects of opioids, and they start having another problem, which is they're now cycling from withdrawal. They develop physical tolerance and physical dependence. They start going into withdrawal, and really they're using at this point to stop withdrawal. And most patients that we see coming into treatment are in this situation where they're not really using to get high anymore. They're using to avoid withdrawal, which, although it's not life-threatening from a medical point of view, feels like it's life-threatening. And it goes on a long time. So I'm going to talk about methadone for opioid use disorder treatment. It is the most effective. It's kind of our gold standard. There's lots of data going back to the 60s and 70s about its effectiveness. And it increases survival, it increases treatment retention, and it increases employment, it decreases opioid use, as well as the infections that go along with injection drug use and crime. So when they try to cut off methadone programs in some communities because of the stigma attached to it, it's often the criminal justice system that comes around and says, no, we need methadone to help us avert crime in opioid users. We know that the longer you're in treatment, the better you do. We also know that higher doses are more effective than moderate doses. And we know that it's highly cost effective. You can see every dollar invested generally saves $4 or $5 of public money. We also know that methadone is difficult to come off of. After discharge, about 90% of people relapse within a year. It's also very highly regulated. It's dispensed in what we call opioid treatment programs, where patients have to come every day or 6 days a week, at least at the beginning. And they can start to get take-home doses that are extended after a few months in treatment if they're stable, their urine tests are negative for everything else, and they make their appointments. Counseling and urine testing are the main services besides methadone and dispensing that happen in these programs, and the psychiatric and medical services that these patients might need. They try and help people get connected to them, but usually don't provide them on site. Just as a note, methadone for opioid use disorder has to be done through these programs. It's illegal to prescribe them as a physician or a practitioner in the medical setting for opioid use disorder. You can prescribe it for pain, although that's not recommended generally, as it's probably even less safe than other opioids. So methadone is a full opioid agonist. That means it attaches to the mu receptors in the brain and turns them on. It also has active metabolites that also activate the opioid system. It starts within a half an hour or an hour, you get the effect, and it lasts a long time. It and its metabolites last a long time, so that a single daily dose is effective for opioid use disorder. It cuts down on craving and withdrawal symptoms, even as a single daily dose. If you're trying to treat someone in acute withdrawal, say in the hospital setting, usually a dose of 20 to 40 milligrams will work, but that's not a maintenance dose. Usually maintenance dosing is 80 to 120 milligrams, and that's the dose that's required to really cut craving and really get people to stop using opioids. It's extremely effective at doing that. The mechanism for how methadone works is it increases your tolerance really a lot. So, so taking heroin doesn't really do much in terms of adding to the effect. So people don't tend to use. There are some drug interactions with methadone, mostly some of the older HIV medicines, rifampin, anticonvulsants that you have to watch for, and sometimes doses need to be adjusted for those medications. So when you're talking to somebody about their methadone maintenance treatment, I think it's important for medical providers to do something about that, to question patients and to provide support. A lot of times people are getting the message that methadone is not a good idea. They may get this from family. They may get it from other people who see methadone as just taking one medicine instead of one drug instead of another. But you can support people's methadone use because it's highly effective for opioid use disorder. That doesn't mean their whole life gets better because of it, but their opioid use often is highly suppressed. So you can ask patients, how are you doing in treatment? What have your recent urine test results been? How many take-home doses do you have? That means that's probably the best measure of their stability in treatment. They don't get take-home doses if they're using other drugs, or if they're using opioids, or if their dose is unstable, or if they're not going to counseling. So that's a really good question to ask. And most people start at 6 days a week going to treatment, but if they're going, say, 3 or 4 times a week, that's a really sign that they've been stable for quite a while. Their dose trajectory, if they're using opioids or other drugs, trying to assess, is the dose going up or down? Are they actually resisting an appropriate dose increase and still using opioids on top of the methadone? You really want people to stay in treatment, and again, they'll get mixed messages from the community. That they may get a message from the program that they should stay in, but they may not trust that view. So you can say, you know, that from your perspective, you met patients, you should stay in treatment until the consequences of your opioid use, that is the medical consequences of their addiction, the psychiatric, legal, family issues, all of those things are stable before you even try to get off methadone, because it's going to be difficult to get off methadone. You know that, and it'll take a long time. You can also discuss with them the possibility that if they do really well in treatment, they can get extended take-home dosing. They can actually get a month's supply of methadone at once, although it's pretty rare to get that stable. And you have to be doing other things in the community in order to get that long of extended take-homes, but it is possible, and it's an alternative to tapering due to how hard it can be to maintain yourself in a methadone program. So buprenorphine for opioid use disorder, we'll go through some of this quickly as well. The 2000 Federal Drug Addiction Treatment Act allowed physicians to prescribe buprenorphine or any drug that's been approved for opioid use disorder that isn't a Schedule 2 or 1, so it has to be a Schedule 3 medication. And the physician, or now nurse practitioners and PAs, can do also prescribe buprenorphine. They have to do a longer training. Physicians need to do an 8-hour training, get a federal waiver. And then in 2002, the FDA approved buprenorphine, naloxone, and all the data in clinical trials show that outcomes are superior to psychosocial treatment alone. And like methadone, longer duration of treatment is more effective in reducing the consequences of addiction. Compared to methadone, if you look at people in treatment, buprenorphine and methadone are both really good at getting people off opioids and decreasing craving. However, methadone seems to have an advantage over buprenorphine in terms of retention in treatment. And this is it has been shown in many studies, and retention in treatment is kind of the gold standard for effectiveness. So methadone may be slightly more effective, but it is also much harder to get, in the sense that buprenorphine can be prescribed in general practice. So the barriers to treatment, having to go every day to get the medication and having it observed, is not the case for buprenorphine. So buprenorphine, unlike methadone, is a partial opioid agonist, so that means it's safer than methadone. So you take more and more buprenorphine, and the receptors are only activated so much. So very hard to overdose on buprenorphine, and really impossible with buprenorphine by itself. You need to have other things on board as well to have an overdose. It has high mu receptor affinity. That means it grabs on to the opioid receptor very tightly, and when it's there, it blocks other opioids. But it also means that if you're on a full opioid and you're feeling okay, you're not in withdrawal, and you take buprenorphine, it can displace the other opioids and turn the receptor down and cause what we call precipitated withdrawal in patients who are tolerant to opioids. So you can't just start it until someone has some withdrawal. So it's formulated with naloxone. There's a lot of confusion about this. Naloxone is not active when you take buprenorphine as prescribed, which is under the tongue. The naloxone isn't even absorbed, just the buprenorphine. But the buprenorphine is what blocks other opioids because of its high receptor affinity. So you have to, in order to start it, you have to do what we call induction. Patients have to enter mild to moderate withdrawal, and then they can take buprenorphine. It'll actually turn the receptor up a little bit and help them feel a little bit better. It does take a few days. Patients vary in how long it takes to get stabilized on buprenorphine. It can be the first dose, or it can be a number of days. Usually people will feel better and better each day for a number of days until they're stable. Home induction is what we're mostly doing now, and I think most practices are. There have been some studies showing that it is as safe and as effective as doing induction in a clinic setting, where you actually watch them take it, make sure they're not having precipitated withdrawal, etc. We can do it at home. We just have to give them a lot of education about how much withdrawal they need to be in order to start the medication. Getting on buprenorphine is easy if you're on a short-acting opioid. Even if you're on really high doses of heroin or morphine or oxycodone, it really doesn't matter. Buprenorphine works really well. The one exception is methadone, and it's because of those active metabolites. If people are on methadone trying to get onto buprenorphine, it's quite a bit more difficult. And folks recommend tapering the methadone dose to 30 milligrams or so before doing the change. And this is risky for patients if they're coming off of a methadone maintenance program where they've been doing well. We really don't recommend people taper from their dose of 80 or 100 milligrams of methadone down to 30, because that really exposes them to risk of relapse. But some people do it, and some people are successful. It's just pretty difficult. There are other formulations of buprenorphine. There's an implant that is approved. You put it in people's arms. You can put up to 4 of them, which is 8 milligrams of buprenorphine. We haven't used it much because people have to be stable on that 8 milligram dose or less, and then they have to get these implants. There's also a monthly injectable version that was recently approved. And really the data shows that it's better than placebo. It hasn't been shown to be better or worse or the same as sublingual buprenorphine. So this is just a graphic of how buprenorphine works. You can see the middle line there, partial agonist. So that means a dose is going up as you move right. It turns the receptor on, and then at some point, really, buprenorphine doesn't make the receptor go on anymore. Unlike methadone or heroin, which you take more and more and more of it, and you'll overdose eventually and you'll die. So buprenorphine is safer. Naltrexone's on the bottom, and it's an antagonist, so it doesn't turn the receptor on at all. It does block the receptor. So that's why buprenorphine doesn't cause overdose by itself. So this is, going back to our slide, this is our simple version of opioid addiction. And then treatment is really trying to get somebody in that place where they're not euphoric, not in withdrawal. Methadone and buprenorphine both do this very, very effectively. Trial of buprenorphine, this is one from 2003. They had 40 people in a trial. They were addicted to heroin. They randomized them to buprenorphine once a day versus a buprenorphine taper with a placebo attached to that taper. And everybody got counseling and therapy groups. They were followed for a year. You can see that 70% were retained on buprenorphine. Nobody made it on the placebo retention in a year. 20% of the placebo group died. This is a highly morbid condition, and I think just points out you don't need a very big trial to show a benefit for buprenorphine or methadone. This is just looking at Baltimore, Maryland, which instituted a lot of buprenorphine prescribing. We'll talk a little bit about that later. In the 2000s. And you can see the green line on the bottom is buprenorphine patients. The blue line across the middle there is methadone patients. They didn't really expand methadone treatment that much over the course of time. But you can see with buprenorphine going up, really cutting heroin overdose deaths quite a lot in Baltimore around this period. So it works in a clinical trial and it works in the real world. So naltrexone, I just want to say a word about naltrexone because there's new data about its use in opioid addiction. It is an opioid antagonist, as I mentioned. It doesn't have any diversion risk. Nobody wants to take it, especially if they're addicted to opioids, because it will cause withdrawal. The trick is you have to get off the opioids completely before induction onto naltrexone. The oral formulation of naltrexone had a number of trials in this country that showed it not to work, but there have been some trials with monthly injectable naltrexone, which is called Vivitrol, and it's been FDA approved for alcohol use disorder, but also opioid use disorder. Recently, there was a trial, so you can see the reference at the bottom. That's called the XBOT trial, and it used extended release naltrexone, and it compared it to buprenorphine. The results really were that you could get more people onto buprenorphine than naltrexone. You can see the numbers there, 94% versus 72%, and fewer people relapsed who were on buprenorphine. So it wasn't quite as effective as buprenorphine, but those people who got on it, the people who actually made it through the process of getting off opioids and onto naltrexone, they did just as well as the people on buprenorphine. So there is some evidence that it works if you can get people on it. Trick is getting them on it, and almost everyone who shows up for at least outpatient treatment, if you talk to them about naltrexone, they will choose buprenorphine because they don't have to go through the whole detox thing. So antagonist or agonist treatment with buprenorphine or methadone should be offered to those people who are unable to complete detox if they initially try for the naltrexone route. So buprenorphine in primary care, really it hasn't been widely used over the country. There have been studies of how many people get the waiver. Most people who get the waiver don't treat very many people, so access within the medical system has been quite poor. There are a number of reasons for that. There's why primary care buprenorphine is difficult. One is that a lot of primary care docs can't necessarily see someone really quickly, like a new patient appointment within a week or two, which is the schedule that works for people with opioid use disorder who are seeking treatment. They don't want to wait around for weeks to get their new patient appointment. And maybe there's an appointment, and maybe there's going to be a couple of appointments before they get their induction, so patients may drop out. So that's one barrier. Also, when it was recommended that you do the induction in the office setting, that's another barrier for primary care docs. You also have to see people pretty frequently. We usually see people every week early on in treatment, and that can jam up your primary care schedule as well. A home induction can help a little bit, but still you got to see people pretty frequently until they stabilize. And some patients take quite a while to stabilize. You got to figure out how you're going to do the urine testing, the prescription logistics, and do it in an organized way. Trying to link people to psychosocial services that may not be available in primary care is another barrier, although there's not much evidence that additional psychosocial services have much effect on outcome compared to just getting the medication in a primary care kind of setting with good support around taking the medication and encouragement to stop using opioids. There can be difficult decisions. You really don't want to stop the medicine because you know it saves lives and prevents overdose, but what if the patient's not playing by the rules that you've set up? And we'll talk more about this later. So some physicians will do a very minimal practice, just restrict their prescribing to folks maybe who are on prescribed opioids and not doing well, or having trouble controlling the use of a prescribed opioid. Those patients do really well on buprenorphine, so you might start with that. Or maybe patients in your practice already who you realize have an opioid use disorder, but a lot of people are reluctant to like put out the shingle, say, you know, I'm treating addiction here, because they know a lot of patients will come. So there are a lot of advantages of doing buprenorphine in primary care. Really, our setting in primary care is built for chronic disease management. This is not a condition that goes away ever, really, and people need ongoing medication and support. It also, for patients, they really appreciate getting the treatment in a medical setting as opposed to an addiction treatment setting where there's a lot of stigma attached to that. They aren't as much contact with active drug users like they would be in a methadone program. And really getting it in primary care facilitates the mental health problems that are really common comorbidities, also medical comorbidities. Think about the Hep C or the HIV, preventive care, everything we do in primary care. You can do it, and you can also do buprenorphine, and patients really appreciate getting all the services together. Buprenorphine is really a great tool for chronic opioid therapy patients who are for chronic pain who are not doing well and who are unable to taper off high doses. It's a really important tool, and even if that's all you did with it, it would be great if you could get primary care physicians to take this on. And then, of course, there's the public health benefit of treating opioid use disorder, increasing access to treatment. The substance use disorder treatment system is not able to meet the demand of opioid use disorder treatment in our communities. And really, buprenorphine, it's one of the most gratifying forms of treatment of anything I do, for sure. People's lives change. People get their kids back. People get their jobs back. It's great to see how well people can do. Not everyone does well, but boy, is it life-changing when it works. So there are a number of models of trying to do primary care opioid use disorder treatment. There is the reference at the bottom is Annals of Internal Medicine article that summarizes these models. There's something they call practice-based OBOT, or office-based opioid treatment, where they're really not providing a lot of additional staff. Maybe maybe somebody's helping a little bit, but mostly it's just the doc on their own. I've done this myself in a primary care setting. You can do it. It's hard to treat a lot of patients, but you can do it. This kind of model has been adapted and shown that you can treat patients in the HIV setting. Prenatal clinics can do it. It's just kind of hard to do a lot of patients. You could do some. And then there are more systems-based models, which have been shown to be able to treat a lot more patients. And really the common denominator of all these system-based models is you add staff. You need dedicated staff doing this. So there's a couple of versions of this. Some have called hub and spoke, where maybe there's in Vermont, the way they do it is they have a methadone program as a hub. They start a lot of patients there. If they stabilize on buprenorphine, they get transitioned to spoke primary care clinics or behavioral health clinics, and they continue the medicine. That's one model. Some patients in that hub and spoke in Vermont actually start in the spokes. They can start treatment, but they kind of have a risk instrument they do. And if they're high risk, they start in the methadone program, even if they're starting buprenorphine. And if they're lower risk, they can start in the spoke. The collaborative care models, Baltimore and Maryland has done this, where they set up clinics to start buprenorphine, and it's like a central induction facility and within a city. It's not necessarily a methadone program. And then they, again, when they're stable, get them to primary care docs to take on the prescribing. So centralized induction, stabilization, referral. If the patient relapses or is having trouble, they can go back to the hub. That's one model. Massachusetts nurse care manager model, I'll talk a little bit more about. That's what we've instituted at Harborview. It's been done in multiple clinics in Massachusetts. And then other models that are system-based, like telehealth, where you connect multiple clinics to expert support for the staff trying to take care of people. Usually that when it's been successful, has been associated also with some staffing in those local clinics. So they get expert support from an academic center for difficult cases, but they do the treatment locally. And then finally, there are some models which are not starting in primary care at all, but starting from the emergency department or the inpatient hospital, and then trying to link people to primary care. That's another kind of model, kind of getting people maybe who aren't even seeking treatment to start buprenorphine. So barriers to treatment, you can see the reference here. This is a little bit of a different way to try and think about what kind of services are provided. It's really thinking about a spectrum of policies within any of these kind of programs that determine access to treatment. So if you got to do a lot of calls and visits prior to getting medication, it's a higher barrier approach. If you can come the same day and get the medicine right then, it's a lower barrier of care. Or on the other end, what about requirements? Maybe there are other requirements for starting the medicine or for staying in treatment. Maybe some practices might say, if you're using meth, forget it. You have to go to a different level of care. Or some other programs might say, well, no, we'll keep them in. So it's a spectrum of policies that primary care clinics have to figure out. What are we going to do? And the lower barrier programs can maybe target patients who are harder to reach, like homeless folks, people who aren't treatment seeking or have a lot of other problems. You're really trying to get them on the medicines, not worrying about the counseling too much. If they want it, yeah, sure, we'll refer. If not, we'll keep going with the medicine because we know the medicine is really the most important part. And then how many appointments can they miss? What about diversion? If you have a low barrier program, people are missing appointments using other drugs, maybe continuing opioid use. What is our responsibility around diversion? What about untreated mental health problems or if you have a very low barrier program starting patients the same day, how do you get them to ongoing care? So those are some of the issues around lower barrier programs. Everybody's talking about what kind of program. Do you have a high barrier program, low barrier program? Every program has to create policies that really balance access, lower barrier, with maintaining the integrity of the treatment setting. Like just giving the medicine and you can't, and nobody's showing up at the right time. It gets really tough in a primary care setting. There's a lot of missed appointments, but every program has to figure this out. So the Massachusetts model, that's I'm going to talk a little bit more detail about that. It's a program which is a staffing model. You have a nurse care manager providing most of the clinical care, a program manager helping with screening on the phone, scheduling a lot of the paperwork and reporting, and really it makes it easy on the docs. So you can have multiple docs in a clinic prescribing not to a lot of patients, but they really don't have to see patients weekly like you would in the beginning, and so they can see and prescribe to more patients. Massachusetts replicated this model through state grants. Each clinic had to commit to hiring staff and seeing patients. With a nurse care manager, you can treat 100 to 125 patients at any one time, admit two or three patients a week. And we did this through a grant, SAMHSA grant, that was also went through Evergreen Treatment Services, which is a opioid treatment program, and they did this model in that setting. I'm going to talk about it in primary care. So the flow is the program manager does screening, the nurse care manager does a full appointment, the physician does an appointment, makes a diagnosis, and gives a medicine. That can all happen in one visit or on the phone and one visit. And then the nurse care manager may do an induction visit, or that same day they may do a home induction. The nurse care manager will follow up by phone. There'll be weekly visits until they're stable and can extend the duration of time between visits. There's urine testing. And physicians can see the patient really monthly, however much they need for their primary care. Clinical decision making, stable patients will come every month to get a prescription, do a urine test. Unstable patients who are continuing to use other substances or opioids will continue longer, and we'll think about dose increase. We'll think about adding other services, whether it's mental health or sober support, or Harborview as an addictions program with groups, they could go to that. We have weekly team meetings to talk about patients where we have to make tougher decisions. We can also transfer patients to an opioid treatment program that is Evergreen for daily buprenorphine, and they can come back if they do well in that setting. Or they can transition to methadone maintenance or inpatient addiction treatment. Maybe their social situation is too chaotic to be successful. So our progress, we really started at the beginning of 2016, have enrolled about 4 patients per, three patients per week, 12 patients per month You can see some of the demographics, a lot of comorbid mental health problems. Most of our patients have been housed. They have to get through the system. And we've done really well in terms of retention, 6-month retention rate, about 60%. If you get that far, most patients get to a year, and a lot of reduction in drug use and in other emergency and hospital admissions. We've also, as part of this program, trained a lot of docs over the summer, 2016 and 2017, including all the internal medicine residents, so they can prescribe. And now we started supporting some of the other primary care programs at Harborview. So we have a HIV clinic, the Madison Clinic, Family Medicine Clinic, Pioneer Square Clinic. We've supported them as well. The Evergreen model, I'm not talking about, but they've done just as well as we have in terms of enrolling patients and meeting the need. The opioid state targeted response, this is more federal money that's come through Washington State. We call it STR. There are a bunch of projects that, including prevention projects and treatment, and there's what they call hub and spoke, although it's not exactly like the Vermont model I mentioned. The hub and spoke model here, you have to have a primary care site, a behavioral health site, and substance use disorder treatment providers within networks so that patients can find a home in one place or another. They have allowed flexible staffing, so it can be nurse care manager, it can be a care navigator that's not a nurse, it can be administrative support at these 6 networks, and each network has committed to treating a couple hundred patients a year, and that's ongoing. And Harborview is one of those, and we've been expanding the nurse care manager model. So back to our case, buprenorphine happened in the hospital, and that's one of our spokes now in our network. We try and get people started in the hospital. He didn't want groups, so he just came to primary care, and he's been coming. He's been making all those appointments. Team's really bonded. He's bonded with the team. He's not using opioids. He started taking his HIV meds and wants hepatitis treatment, but he's not as ready to stop methamphetamine use. So I'm just going to talk a little bit about a couple projects we did in Harborview to try and figure out our policy. So the first project is a medical student, Claire Simon, helped us with this. It's called Linking Patients with Buprenorphine Treatment, and really predictors of engagement. So we looked at our initial intake and nurse visit, physician visit, and starting medication. Initially, those were not necessarily happening the same day, but we found that when we looked at the first 100 patients that we treated, that a lot of patients didn't actually get medication. So we looked at the first 100 patients who called, and then we tried to figure out how many got medication and what predicted that. Now, our initial policy in the clinic, we weren't sure what we could do in the primary care setting. We made a policy that they had to show up without cocaine or methamphetamine in their urine before we would give them medicine, because we weren't sure we could treat those patients, whether we had enough to within the program to do that. So that was the reason for that policy. And what we found was that patients, let me just try and get to the next slide here. Here we go. So it was only 60%. It was 60% who dropped out by the time they got medication. You can see 100 did the intake interview, and by the end, 40% only got the medication. And it was polysubstance use that predicted not getting medication. Also, if they'd been in treatment for addiction before, that predicted it. So as a result, we decided to change the policy. We said, we think we should try and lower our barrier to treatment. And so we took that away. And then we looked at it again. This was a different medical student. This is a project is less far along, but we do have results. So lowering barriers to engagement in a primary care-based buprenorphine treatment. And again, we looked at patients now before the policy change and after, and we looked at them whether they used cocaine or meth, and we found that the low barrier condition, what we changed our policy to, led to higher rates of medication initiation, especially among those people who are using cocaine and meth. That's the policy change. Unfortunately, we didn't find an overall increase in treatment retention if you looked at 3 months down the line. So what we are concluding is we can get people in, but these people may need additional supports, and we are working on that going forward. So it's an example of how policy might change as a result of what practices you do and what you see in your program. So getting back to our case, the guy did really well, and really the way our team looks at it now is what is the progress in treatment? Is there any? He's still using meth, that's not so great, but his Hep C treatment got done and was successful, and over the course of time, he stopped injecting meth and he started smoking it instead. So we have a lot of conversations about how to switch, and this is more of a harm reduction mode. What could be safer for this guy? Well, the switch to smoking, maybe taking a day off each week, maybe just taking care of yourself while you're using, staying hydrated, nutrition, mouth care, safer sex, trying to use in a safe place with safe people. So he may change further. He may even stop the meth eventually, but we see so much progress in treatment, we're not going to discharge him for the meth use. So this is just a summary slide of what I've been talking about, management of opioid use disorder in primary care. The epidemic is urgent. It requires a lot of efforts. Effective pharmacotherapy for opioid use disorder is available. There are a bunch of models out there for opioid use disorder treatment within primary care. None of them have caught on for sure, and really all have to be adapted to local circumstances. Additional staffing, I will say this, we do know additional staffing really helpful in the primary care setting if you're going to try and serve a lot of patients, and that's what's necessary. And then program policies impact access to care, also the need for support services. So I think that is the last slide. I just wanted to thank everyone for listening. I think there is time for some questions. Feel free to contact me. There's my email. I'm happy to help out with this. A lot of people come and visit our program to see how we do things. We have a manual that we can send around about how to do the nurse care manager model. And we hope you'll take this on and try and get your institutions to support opioid use disorder treatment wherever you can do it. So thank you.
Thank you, Dr. Merrill. This is very helpful. So as I said, we have some times for questions. Just before the questions, done now, yeah. So for the participants, you guys gonna get a survey in your inbox that is gonna be sent at any moment now. So please help us out by answering and giving your feedback. And in a month, you get another one, is a follow-up. And for that one, we have an incentive of $5 that here in the Seattle area buys you a cup of coffee. But regardless, it's always good to get a cup of coffee. So really appreciate if you help us answering this. So now I'm gonna look at the questions here. I've been looking as they get along and try to get to Joe. So first question here is, can you explain why there is a difference in the half-life of methadone and its impacts on different participants? Gives an example, why is that opioid-naive participants may experience methadone with a half-life of up 55 hours versus a tolerant that is just 24 hours?
Yeah, so that's an interesting question. And the answer is really that all opioids act very differently in different people. So there's a huge heterogeneity in how people metabolize opioids and their response to them. Some people, when they take opioids, get a lot of energy. That's a bad thing because often that leads to an addiction. Some people take them and start throwing up and feel horrible, and they don't generally have as much trouble with opioids. But in terms of the methadone issue, you know, it's an observed dosing. They've done studies where they check people's blood level of methadone before they dose and after they dose, and they're all over the map, even if in patients who are taking the same dose. So very big variability in how people metabolize methadone, and there's not a why other than individual differences, maybe genetic, but we don't know completely. But the question is right, that people respond very differently to these meds. So you can't really judge how people are doing based on a dose. Some people need a very high dose of methadone, some people not a very high dose. So it really is all over the place.
Thank you. Another question is, in the PC model, is it necessary to have a separate room or area to have participants sit during induction?
So that's a great question. Answer, no. We haven't done that. If you have a room and you can put the person in the room and do the induction and leave them there and go see another patient in a different room, that's fine. That works well. People can be in the waiting area or go and get a cup of coffee or whatever. But increasingly, we're doing home inductions. And now it's really the exception to do clinic inductions in our program. If you were going to start out doing buprenorphine in your clinic, it's good to kind of get used to it so you know what to look for. You can start to see people's withdrawal signs. Now I don't really need there are clinical tools you can use to gauge people's degree of withdrawal. I don't need that anymore because I can look at them and see, but getting used to that is helpful. So doing some clinic inductions can be helpful as you're getting started. But really most patients, if you educate them well, give them the clinical opioid withdrawal scale to take home with them so they can even score themselves, it works very well.
Okay, thank you. Another question, you mentioned a summer training program for physicians at HMC. Is that a continual resource? And if it is, what are the requirements to participate?
So yes, we've been sort of opening up these trainings. We've done one in July, August, September, because that's the new internal medicine residents. That's when they start, and we want to make sure we cover everyone, and they're on different rotations. So we have been doing 3. They're usually on a Monday morning, and you can email me if you want to get connected with that. We haven't got the dates yet, but if you email me somewhere in the May or June range, we'll probably have it set up by then. And we have been able to open it up to non-UW, non-Harborview people, and trained a lot of people in the community.
Great. Okay. Another question, can you talk a bit more about using Bup for treatment of pain? When do you consider using it in the context of participants who you haven't diagnosed with OUD, but have opioid dependence from years of prescribed opioid for chronic pain?
Yeah, so this question is a big question, and I was thinking of trying to include some of this in my presentation. It just didn't quite fit. It was the wrong case, actually. But I think that the first thing to figure out when you have folks who are being prescribed opioids for pain is what is their dose, because higher dose patients are different than low dose people who are taking it intermittently. And it's the high dose patients that we have trouble with. And all the criteria, all the guidelines now for use of opioids for chronic pain really recommend that they not be used, or that they be tapered. But I think we run into problems when we taper, and I think there's increasing evidence that unless we start paying attention to how patients do when we taper them, and whether they really do have an opioid use disorder, whether it was caused by the prescribed opioids or not, I think we're not going to be serving patients well. So making that diagnosis, we do have, there's another slide, Bia, maybe you could put up the slide. Sure. About the last slide. Just want to put up the opioid use disorder criteria. This is DSM-5, and the criteria are listed on the left. The yellow is new for DSM-5, and they added craving. And actually, craving to me is one of the most important symptoms. And do you find that you think a lot about your opioid pain medication during the day? Do you think about, do I need it? Should I take it? I wish I could take it. Do you have those kinds of thoughts a lot? To me, that's craving. And I think is an important criteria for folks taking prescribed opioids. Now, DSM-5 says that if you, it's the yellow down below tolerance and withdrawal, if you have tolerance and withdrawal from your opioid pain medicine and you're taking them exactly as prescribed, and you have no other criteria for opioid use disorder, then those two criteria don't count. But for me, I can almost always find criteria. Either they're not taking it exactly right, they're taking more one day and having to sort of skimp other days to get to their next refill, or they're thinking about it a lot, or they've tried to cut down and they haven't been able to, or they're taking more than they intended over time. There's just a lot of criteria there that you could use and make a diagnosis. And then the question is, how do you talk to the patient about it? And I think bringing out the criteria, you're not talking about addiction, you're not talking about substance use, substance abuse, you're talking about a use disorder. And people do have negative consequences from opioids. Maybe they have sleep apnea, maybe they have less energy, maybe they have craving tolerance and withdrawal, maybe they have all of it. And my experience is that folks on high doses of opioids who are able to see, yeah, this isn't a use disorder, and there's effective treatment. I don't have to switch doctors. I can just get it here. They do extremely well on on buprenorphine. And so the use of buprenorphine, not for pain, but for a use disorder, maybe as a result of pain treatment over time, I really want to support people in doing. And that might be something that you get trained to a waiver and everything. You don't treat anybody else, but you treat your patients who are on higher doses of opioids with buprenorphine. I think we can save a lot of lives, and people do great on it. Their pain is not completely controlled before they start buprenorphine, because opioids don't control pain completely, and they're not in complete control of their pain afterwards. But they get just as much benefit and a lot less up and down in terms of the pain treatment when they use buprenorphine because of how long it lasts. So yeah, I'll stop there on that subject.
Okay, thanks. I have a couple of questions here about are we gonna have this available, the PowerPoint. So please note our website below this slide, and it was also said in the first slide, this is gonna be available on our website, the whole presentation. You can also email us if you want any particular, like just a PowerPoint or something like that. It might be available there as well. There is another request about having, if it's possible to have the manual. I'm not sure what manual is being referred here to, but
yeah, I think that's just our nurse care manager model.
Oh, okay.
And happy to send that to you, Bia, and then you could distribute, or you can just email me, and I'm happy to send it.
Okay. Okay. Either way, good. We'll make it work then. Thanks. Then two last questions. We are 2 minutes to finish, but let's see if we can fit it in. So one is to elaborate on the nurse care manager role, especially the alternative mentioned regarding a non-nurse care navigator. What does a non-nurse care navigator look like?
Yeah, I think that's a great question, because that's really one of the key things with this opioid STR project. There's a lot of different models going out. The nurse, I think the nurse is great, because the nurse can deal with helping the patient administer the medicine correctly. There's a lot of stuff early in treatment about helping the patient take it, when to take it, how they're taking it, whether they're holding it under the tongue right. There's a lot of medication stuff going on that nurses are good at. There's also a lot of urine stuff going on. So who interprets the urine test? Can a nurse do it? Yeah, nurses get good at that. Other people who are behavioral health specialists or social worker may or may not be able to do that or want to. And then the last thing is the prescriptions. There's a lot of logistics, getting prescriptions to the right pharmacy at the right time, not getting the prescription unless you come in and get seen and get your urine. So there's a lot of that kind of logistics. Nurses do all of that extremely well, and they can assess wound care. They can start to assess if there's a mental health issue that needs to be addressed and get them to services or back to their primary care doc. I think that it's possible for other people to do those things if they're taught well. And some of the nurse care or the care navigator idea is maybe we can do this across systems. So maybe you can have a care navigator who meets the patient, helps them get started in an emergency room, and kind of helps them get to their ongoing care location, whether that's in an addiction program or a mental health program or primary care. So, and I just haven't seen tons of data supporting that. I think the nurse care manager model, the hub and spoke models, there's data about it. The care navigator models, I think, are everybody's interested because they cost less than nurses, but nurses do a lot of this stuff really well. And we really need to make our system such that it's financially viable for the nurse to be able to do it. And that means letting them bill or some kind of value-based payment for this kind of care in whichever setting it takes place.
Okay, we are wrapping up now with the last question. In advance, thanks so much for participating on this webinar, and particularly thanks to Dr. Merrill. Basically, can you speak briefly about your weekly medication-assisted recovery support, MARS, peer support?
Great, thank you, Harvey, for bringing that one up. So, as part of our program, we have started this program. It's really support for patients who are on medication for addiction, and really it's the buprenorphine. And any of our programs at Harborview, patients on buprenorphine can go to this group where they get support, they get education, they do education. Actually, it's been a really positive addition to our group. It's not addiction treatment, it's really peer support, but very often patients, when they go to AA or NA groups, they're either they don't feel comfortable talking about their medication, or if they do talk about their medication, some members of the group might think that that's not an okay way to get in recovery, and so it can be hard for patients. So this MARS program, we call it, has been great for those patients, and they have really, I'd say that, these patients have done really well. They've gone to School of Medicine to talk about their experience. They've spoken publicly about their experience, so they get a lot out of it, as well as really giving back to the community in support of medication-assisted treatment, which is really the most effective treatment model we have.
Perfect. Thanks so much. Again, for people asking about our emails, and is this going to be recorded, the email is on the bottom of this slide that is also announcing our next webinar. If you are looking for a specific email of Dr. Merrill, it was showed in the previous slide, so you can go to our website or email us and we'll give it to you. And it was recorded, and it's going to be everything available. Thanks so much, everybody, and again, thanks so much, Dr. Merrill.
Thank you.